continue our discussion on cost, quality, and access to health services. And in this module, we're going to focus particularly on the access piece. We're going to be talking about what access itself means, some reasons for disparities in healthcare, and reasons for unequal access. So let's first talk about access to care and how we are going to define that. Access to care, we can think of that as an individual or a patient's ability to obtain really needed but yet convenient healthcare services that are affordable and acceptable, and obtain all these in a timely manner. But not only obtain these services, we want to obtain and receive effective healthcare services. Now, when we look at it from an individual standpoint in regards to our healthcare status, our ability to access healthcare services is one of the most important key determinants of our individual healthcare status. The Institute of Medicine, or the IOM, states that there's 3 steps all individuals must go through, no matter who you are, to obtain this good access to healthcare services or obtain this convenient and acceptable access to healthcare services. The first of those steps is that we as an individual must somehow first gain entry into the healthcare system. I know that sounds very simple, but some individuals do have trouble even gaining access into the healthcare system itself. We know from past modules that without insurance or some form of third-party payment, it can be a little bit more difficult to gain access into the healthcare system to start receiving these needed services for effective healthcare. Now, once we gain access into the healthcare system overall, now we need to make sure that we can obtain the services that are needed. So just because we're in the system now does not necessarily mean that we are conveniently located to services, or we're close enough to services that we need that we're able to get those in a timely manner. So now we have to start focusing in on gaining access to these sites of care that we need to receive needed services. So for example, we may live in a rural community, we're in the healthcare system, but we need some form of oncology service that is not offered in our area. So now we have to start down this road of trying to find appropriate, convenient, and needed oncology services for this particular type of specialty care that we need. Now, the third and final step that the IOM states that all individuals must go through once we've gained entry, once we've gained access to the particular site of care that we need, now we need to focus in on finding a provider that can really work to meet the needs of us as an individual patient, and with whom we can, as a patient, really start to develop a relationship that's based on mutual communication and trust. You're going to be talking with your physician or your provider about some very serious and intimate details of your healthcare status. So you need to be able to have a relationship with a provider that you can really trust, and that you can really have this open level of communication, so that we as providers can go back to start offering this really effective health care and these really acceptable forms of healthcare services. Unfortunately, we do, however, see disparities or a great difference in how individuals are able to access healthcare. So let's first discuss some of those disparities that we see, and then we'll get into a couple reasons for unequal access to healthcare services. A few of the main reasons we see for access disparities revolve around socioeconomic and minority status. So those individuals that find themselves in lower socioeconomic status or in minority groups are often associated with lower overall healthcare usage and or access overall. So we see non-white persons under the age of 65, they're about 20% less likely to be insured compared to their counterparts. And those living in rural areas face greater access barriers overall than those living in urban areas, which leads us into a couple reasons for unequal access. Now, as I said, on the individual level, your minority origins weigh heavily on your ability to access healthcare services, your socioeconomic status if you are in the lower income range. We also see people with lower education, those with disabilities, chronic illness, and of course those that are uninsured, all have difficulty obtaining equal access to health care. Again, income, race, your occupation even may prohibit you from obtaining equal access to needed healthcare services. And then your geographic location, if we think back to when we talked about provider distribution across the country, we see a lot of issues in the rural setting. We know there's a physician maldistribution in our rural settings. Particularly with our primary versus our specialty distribution across the country, not just in our rural areas, but think about our ratio of primary physicians to specialty physicians. We know specialty physicians heavily outweigh our primary physicians, and so we see a difficult time accessing primary care services because we simply do not have enough primary care physicians or providers. Also, our service type of payment. Think about the type of insurance you have. Are you on a government program? Do you have Medicare or Medicaid, a state-sponsored program? Do you have a private insurance? Are you self-pay? Do you have TRICARE, a military type insurance? So again, your payment source type also factors into your ability to access healthcare services. So, really think about and tie back into our conversation about the physicians and our workforce. Think about the maldistribution of physicians across the country. Think about our ratio of primary to specialty physicians, and really the economic state across the country. Those that are more economically disadvantaged and those areas that are more economically disadvantaged have a harder time getting physicians, getting practices, getting needed services into their area. Now, the government did create some programs that try to address these issues that revolve around access. And the first one we saw of that was the Shepherd-Towner Act of 1921. So the government involvement in healthcare services really grew post-World War I as we're recovering from World War I and working towards and starting to get involved in World War II with the Shepherd-Towner Act. Now, what the Shepherd-Towner Act did was work to provide direct primary care services to more of our economically disadvantaged mothers and children who could not otherwise receive health care services. So post-World War I, we had the Shepherd-Towner Act. We start to move into World War II, and during and after World War II, we saw this program grow, and the government offered more comprehensive care to lower income soldiers' wives and their children. So we saw that the government initiatives start to grow as our country was starting to recover from these major world wars. Now, this access issue overall really drove our country and pushed us towards what we call the Great Society programs of the 1960s. Now, recall what was the major program that we offered or that was created in 1965, and that was the Center for Medicare and Medicaid Services. So CMS was created 1965 during this Great Society program boom. And post-1965, after the creation of CMS, cancer screenings and immunizations were added in as a part of the services covered by CMS. In 1997, the program went a step further and authorized funds to be distributed to help the states create what's called S-CHIPs, or sometimes you'll hear it referred to as CHIPs, and this is the State Children's Health Insurance Programs. And these were created particularly for children who did not qualify financially or economically for many of the Medicaid programs out there, but they still did not make enough, or their parents did not make enough for them to qualify for private insurance. So we wanted to make sure that the children were starting out their lives healthy and were able to have access to care so that they could lead healthier lives. And the states did this through the S-CHIP or the CHIP program. So just to review and recap, going back to how we define access overall, just remembering that we need to have effective and needed care that's affordable, and we can get that in a timely manner. And those 3 steps that the IOM says all individuals must go through in order to obtain good access or desirable access to healthcare services. A couple of indicators that we see for healthcare disparities and reasons for unequal access, mainly revolving around your geographic disbursement, your socioeconomic status, and your minority status, and then a few of those ways that the government tried to interject themselves to help address this access issue.